Good afternoon. My name is Jarrett Casanidi, Coordinator for the AIDS Education and Training Center's National Center for HIV Care in Minority Communities. Before we begin today's webinar, Meeting the Healthcare Needs of Lesbian, Gay, Bisexual, and Transgender People, Ending LGBT Invisibility in Health Centers, I would like to introduce you to today's presenters. Javier Salazar, the AETC NCHCMC Project Director. Mr. Salazar has over 20 years of experience working in HIV and health-related policy, government relations, advocacy, program development, implementation, and evaluation. As Senior Director of Programs for Health HIV, Javier leads the management and implementation of Health HIV's capacity building, education, training, evaluation, and research activities. Also joining us is Dr. Harvey J. McAdon of the National LGBT Health Education Center, the Fenway Institute, Fenway Health. He is also Clinical Professor of Medicine at Harvard Medical School. Dr. McAdon is the lead editor of the Fenway Guide to Lesbian, Gay, Bisexual, and Transgender Health, published by the American College of Physicians in 2008. In March 2011, he served on the Committee on LGBT Health Issues and Research Gaps and Opportunities of the Institute of Medicine of the U.S. National Academy of Sciences for the Health of Lesbian, Gay, Bisexual, and Transgender People, Building a Foundation for Better Understanding. Before we get started, I'd like to let you know how you can download the presentation and supporting materials, including the AETC NCHCMC fact sheet and application. To do this, click on the document title just above the WebEx screen. Then hit File and then Save As. These supporting materials, as well as a recording of this webinar, will be posted on the AETC NCHCMC website at www.nchcmc.org. During the presentation, we will ask you a couple of questions using the polling function. Please refer to the box on the bottom right of your screen to input your answers. All your answers will be anonymous. At the end of the webinar, we will have a short question and answer period, so please hold all of your questions until the end. And Mr. Salazar, would you like to get us started?
Sure. Thank you, Jared, and thank you all of you for being on the call. I want to let you know that there are about 110, and it keeps going, attendees on this call, so there is a lot of interest in this topic, a very important one. And I want to thank you all for taking time out of your busy days to participate in this webinar. As you know, this webinar is sponsored by the AIDS Education and Training Center, National Center for HIV Care in Minority Communities, in collaboration with Fenway Institute and its National LGBT Health Education Center. And so I want to thank Dr. McAdon for presenting on this very important topic. As you know, addressing the primary care needs of LGBT individuals is extremely important, especially as we enter into a time of potential healthcare expansion and its accompanying uncertainty. As community healthcare providers, we really must do all we can to increase our capacity to serve all populations, especially those who have been historically underserved or otherwise disenfranchised. And in that vein, I want to share with you a little about the AIDS Education and Training Center and National Center for HIV Care in Minority Communities. It is quite a mouthful, so we usually call it the AETC NCHCMC. And the goal of this project is to increase access to comprehensive, high-quality HIV primary care for racial and ethnic minority communities who are severely impacted by HIV. It's duly funded through the Health Resources and Services Administration's HIV/AIDS Bureau AIDS Education and Training Center program, and through the Department of Health and Human Services Secretary's Minority AIDS Initiative Fund. The purpose of this project is to develop, improve, and enhance the organizational capacity of non-Ryan White funded CHCs to provide primary medical care and treatment to minority individuals living with or affected by HIV. And as we know, CHCs present an existing platform that have provided and can provide quality primary care services for racial and ethnic minority communities. The comprehensive structure of CHCs offers the potential for accommodating HIV care and treatment into primary care, and the anticipated impact of this expanded capacity includes integration of new providers into systems of HIV care, and identification and delivery of best practices and clinical guidelines to providers that serve these communities. This project is intended to enhance the capability without direct Ryan White services funding of primary care providers and CHCs so that they can begin to increase their capacity to provide culturally competent, compassionate, high quality, and life-sustaining HIV care as part of their overall expansion. And finally, this AETC supports the President's National HIV/AIDS strategy in reducing HIV-related health disparities by expanding HIV care and treatment capacity at the community level and facilitating linkages among service providers at that level. So with that, I want to thank Dr. McAdon for presenting, and I'd like to hand it over to him now.
Thank you very much, Javier, and thanks, Jarrett, for your kind words and introduction, and also thanks to everybody for participating today. I do hope that you will feel that this was a worthwhile expenditure of time, and that clearly the health of LGBT people is very intrinsically related to the work of Health HIV. So we hope that we can collaborate on more efforts in the future. What I really wanted to talk about today was LGBT people, the disparities that exist in that population, and how to help end invisibility in clinical settings. Our specific learning objectives are really to go through health disparities, to identify strategies for taking a sensitive history, including sexual orientation and gender identity, and be supportive of those issues with your patients, and to understand the resources and trainings that are available from our center at the Fenway Institute at Fenway Health. And we're happy to talk with you about that after this session. A lot of people say, well, what's special, or why is LGBT health distinct? I think the answer is that there have been a number of health disparities which have been described in the population. Unlike some health disparities, these are not necessarily due to genetic issues or biologic issues, but really related to a long history of stigma and discrimination, bias in healthcare, and social determinants of health, which have affected LGBT people for many, many years. Certainly in terms of healthcare, a number of studies have shown bias among physicians who are uncomfortable providing care to gay patients, a history of patients who would change providers upon finding out that their provider was gay or lesbian. A study of medical students in 2005 showed that 15 to 17% reported either mistreatment of students at medical schools or hostile environments. I know here where I work, a number of students still talk a lot about that, particularly when they go on clinical rotations in hospitals. And finally, in 2011, there was a study done by the National Gay and Lesbian Task Force looking at health of transgender people, where there's really outright refusal of care still being reported, and certainly a lot of people say that doctors they see are uninformed about how to provide transgender care, even when they're willing to try and do so. And I do think that our center has a mandate to try and deal with that issue and to deal with all of these issues, and today will just be a start. So in terms of the impact of stigma and discrimination, it's important to be thinking about just really some of the things that we've heard about in the news over the past couple of years. So that in the upper left-hand corner of this slide, you see a picture of Tyler Trinetti. He was a college student at Rutgers University in New Jersey and was videotaped by his roommate having sex with another man. When he saw that, he was very upset and ended up committing suicide by jumping up off the George Washington Bridge. Over here on the right is a transgender woman who was found dead 6 weeks after she reported abuse by the police in the community where she lived. So clearly we live in a world where there's a great deal of discrimination. We hear a lot about bullying in schools at this point in time, and even abroad. And this is a photograph from 2 men being hung for sodomy in the Middle East. Things happen to people which, even though at a great distance, have an impact on people here in the United States, because people who are lesbian, gay, bisexual, or transgender can't help but being affected by what they hear is happening to people like them around the world. Finally, the social determinants of health are important issues for us in terms of taking care of any vulnerable populations, but that it's important for us to recognize that LGBT people come from all socioeconomic groups, cross racial and ethnic boundaries, and truly represent a cross-section of people in the United States, so that they are often doubly affected by issues that affect vulnerable populations, and this contributes to some of the health disparities that they experience. As Jared said in his introduction, there's a recent study put out by the Institute of Medicine called The Health of Lesbian, Gay, Bisexual, and Transgender People, and the Surgeon General's report, Healthy People 2020, which have been very important documents put out by the federal government that have highlighted both health disparities and issues in LGBT populations that are important for both research and changing systems to ensure better access to quality care. In terms of disparities, Healthy People 2020, some of the things that have been highlighted are that youth are 2 to 3 times more likely to attempt suicide, that they're also more likely to be homeless. We've recently been working with the Healthcare for the Homeless groups, and clearly youth is a major issue for them, and LGBT youth is a particular issue for them. LGBT populations throughout the life cycle, from adolescents to older people, have highest rates of tobacco, alcohol, and other drug use. As all of you know, gay men are at higher risk of HIV and sexually transmitted diseases, especially among communities of color, and I'll say a bit more about that in a second. Lesbians have been shown to get fewer preventive services for cancer and other things, and again, lesbians and bisexual women are more likely to be overweight or obese. Finally, transgender individuals have been shown to have a high prevalence of HIV and sexually transmitted infections, significant victimization and mental health issues, as well as suicide. They're also less likely to have health insurance than heterosexual or lesbian, gay, bisexual individuals, meaning that they're often receiving health care, if they can find it at all, very late in the course of illnesses, which again adds to the disparities that they have experienced. And finally, elderly LGBT individuals have additional barriers to health because of the isolation that they frequently experience and a lack of social services and culturally competent providers, but often they don't have family to help take care of them, so they find themselves in very difficult situations. Although there's recently been some change in health policy which assures that there can't be any discriminatory policies towards same-sex individuals in long-term care, access to long-term care facilities has been an issue for elderly couples who are same-sex couples in the recent past. I wanted to get to these slides about the recent incidence data of HIV. This is the most recent data that the CDC published from 2009. to highlight the fact that men who have sex with men account for 64% of infections reported in 2009 when you put together men who have sex with men plus men who have sex with men who also use intravenous drugs. 27% of people get HIV through heterosexual contact and 9% from injection drug use. So clearly we have a big challenge in terms of the population of men who have sex with men, and within that population we see that an increasing incidence among young black men who have sex with men, which has increased by 48% between 2006 and 2009 among people between the ages of 13 and 29. This is an incredible change and something that I think health centers are seeing, even if they may not be aware of this in terms of the magnitude of the problem. And as one health center director said to me, I know we see a lot of these patients, but what I don't know is what are the best practices in terms of preventing HIV in this population. That's not going to be something that I can spend time talking about today, but I know here at Fenway and elsewhere there are a lot of people doing a lot of research now focusing on this, but I think that it's something that needs a lot of attention now and in the years to come. Clearly the benefits of reducing health disparities occur in the areas of both of non-communicable diseases, communicable diseases, as well as behavioral health, and result in reductions in disease transmission, increased mental and physical well-being, reduced healthcare costs, and increased longevity. I think thinking about this, particularly as we think about improving quality of care and cost-effective care, are going to be important things as health centers think about the transition from becoming traditional health centers to patient-centered medical homes. And this, again, is an important topic just to think about in terms of LGBT people as a population and the challenges of providing care for them in patient-centered medical homes, what needs to be done, and what can be implemented to improve their care and lower the cost of care are certainly challenges that we're faced with under the Affordable Care Act. So the question that we want to raise is, having now discussed disparities, is what we can do to translate what we know about disparities into quality care and a positive experience for patients wherever they receive care. And our focus is really on community-based care in community health centers. First, I wanted to go through LGBT demographics so that I can tell you a little bit about some of the concepts and terminology that's used. Partly, I think a number of you will probably already know this, but it's important to emphasize how variable and changeable this is both over time and around the country, so that people may express things differently depending on where they are. I wanted to also emphasize that although LGBT is frequently written as an acronym which makes it look like a homogeneous group, L, G, B, and T are very distinct groups of people that have distinct needs and also demonstrate a lot of diversity within each of these groups. So it's important to think of the unique needs of each. Traditionally, we've had a very stereotypical view of what gay men or lesbians were like, and this was a cartoon from the New Yorker magazine that I always thought kind of reminded me of the past. But now we see that, and I think that we see this every day on television and in the news, there is really a diversity of expression in our own community and globally around LGBT health. So that, for example, this woman here in the middle is actually a transgender woman who I met when I was giving a talk recently. And all of these people really represent the sort of large diversity that we see in terms of how LGBT people live their lives and express their lives. And again, I think that we read and hear a lot about this now but it's important to recognize, and when we look at these pictures, realize that if these people came into our offices, unless we had conversations with them specifically about their sexual orientation or gender identity, we really wouldn't be able to know that. When we talk about understanding sexual orientation, it's more than just identifying as gay or lesbian or bisexual, but there's elements that we have to kind of consider, which include individuals' identity, individuals' behaviors, and some people who just have desires or attraction but may not have acted upon them and have had no sex whatsoever, but still are struggling with issues around their sexual orientation. And we as clinicians can help these people quite a bit. To highlight this discordance between sexual behavior and identity, I wanted to kind of highlight two studies. The first was a study that was done in 2006 in New York City of over 4,000 men. 9.4% of men in what was a mental health survey identified as straight, but also in the same survey said that they had had sex with a man in the prior year. Now, these people who did this were more likely to belong to minority racial and ethnic groups, be of lower socioeconomic status, be foreign-born, and not use a condom. And that among lesbians, 77 to 91% of lesbians had had one prior sexual experience with a man, and 8% of them in the prior year in a study that was written by Dr. Cato Hanlon and published in 1997. I don't have more recent data on that. So again, people's behavior and identity can vary quite a bit, and people often have different ways of kind of describing their identity. So that not all men who have sex with men would describe themselves as gay, as we'll point out shortly, but may have other terminology or other ways of thinking about things and may think of themselves as straight, but still have sex with men. So it's important that we talk to our patients about both their identity and their behavior, as well as their desires. One thing I wanted to highlight is that there are same-sex families living all across the country. This slide is a graphic depiction of data that was gathered as part of the last census that asked people to identify if they were a member of a family that was headed by a same-sex couple. So this was purely voluntary, but showed that there were same-sex couples living in 99% of counties in the United States, with the areas that are colored darker having a higher prevalence, and obviously being in areas that we would normally associate with having a higher incidence of lesbian, gay, or bisexual people living. But nevertheless, people were scattered throughout the country, which means that for clinicians working in community health centers, migrant health centers, rural health centers, homeless health centers, no matter where we are, we're probably seeing a significant number of LGBT people. It just may be that we haven't really spent the time to really learn about them and hear about their healthcare needs. In terms of lesbian, gay, bisexual demographics in the United States, people often think back to the Kinsey study and say that 10% of the people in the country are gay. But recent studies have shown, and here is data from the most recent, that about 1.7 to 5.6 people overall identify as lesbian, gay, or bisexual, with more women than men identifying as bisexual. In terms of same-sex contact ever, sexual contact ever, about 8.2% of individuals identify as such. And in terms of same-sex attraction, the numbers are higher and go up to 11%. So there are clearly a number of issues that we have to sort out when we see someone in a clinical setting. I did want to spend a little time talking about transgender individuals. Gender nonconformity refers to the extent to which a person's gender identity differs from cultural norms for people of a particular sex. And sex is usually the male or female determination that's made when someone's born based on their genitalia, whereas gender has to do with the way that people live their lives. The terminology for issues related to gender identity is culturally and time dependent and is evolving rapidly, so it can vary from one year to the next and also from place to place around the country. I think the three issues that I wanted to stress are that transgender people are people who persistently identify and or express their gender as the opposite of their biologic birth sex. Now, these people don't always, but may have hormonal and surgical treatment. And if they have, they're sometimes called transsexuals or transsexualism. But many people can feel they're transgender and have absolutely no medical treatment. They may dress more as a person of the opposite sex, but not everybody has medical treatment. And I think this goes against what we commonly think, and it's important for us to consider. There are also people who consider themselves as a gender outside either or the construct of male or female. So some people feel like they have no gender, they feel as if they're androgynous or have elements of multiple genders. And some people use the term bigender or genderqueer. There are some cultures that have, for example, in Nepal, there's a term that's called the third gender, where people feel as if they don't really have lives that are consistent with either male or female. And in various parts of the world, there are different ways of expressing this. But I think here in the United States, particularly among younger people, there are a lot of people individuals who really feel as if their gender is something other than male or female. And then finally, there are some people who just enjoy the outward manifestations of gender roles and cross-dress to varying extents. And again, this is evidence of gender nonconformity, perhaps, but would not qualify as being transgender. Although in the past, the term transgender was often used as a sort of umbrella term to talk about anyone who had any gender nonconformity. I think now we try to be a little bit more specific. And each of these groups of people have different kind of issues. I don't think we think of any of them as having any kind of pathology or medical diagnosis, but they do have different health needs. So, for example, transgender people will often want to talk about the possibility of hormonal or surgical treatment, and this is something that can be done and has been done effectively in many primary care settings, and there are many resources available to help primary care clinicians do this. So we get to the point of what do we do when we're with a patient and taking a history. And this is an area where we begin to end LGBT invisibility in healthcare settings. So I wanted to ask at this point a couple of questions and just get a sense of the group as to what your own experiences have been, not in terms of you as clinicians or you as healthcare providers of some sort, but you as a patient, so that when you last saw a clinician for primary care, were you asked to discuss your sexual history? And I wanted to get a sense of how many people even had a clinician who took a sexual history at all. So I'll give you a little bit of time to answer this question, and then we'll see your results. I can say that often when I give this talk in a live setting, perhaps 5% of people say that they had a sexual history taken. I do think that sometimes among younger people the number is higher, but generally it's not very high compared to, let's say, discussions about smoking or other issues that we routinely would talk about with our patients. So let's see how we did here.
And Dr. McAdam, we're just closing it right now. We have about 10 seconds for everyone else to submit your responses.
And for those of you who are precocious and want to jump ahead, I think you can begin answering the next question. Oh, people have already answered both questions, so that's good. So you can see that in terms of the first group, 13 people said that they had had a sexual history taken, and 61 said they hadn't. 32 people didn't answer, and 2 didn't recall. But you can see that the number of people who had a sexual history taken was very few. Interestingly, the next question in terms of, has a clinician ever asked you about your sexual orientation, more people said yes to that than said yes to the first question, 18, with only 53 saying no, and 34 people didn't answer this question. I have to say that this group is a little bit unusual. Generally speaking, in a group this size, I'd say at most 1 or 2 people would say that their doctor had asked them about sexual orientation. And I can certainly say from my own experience that it was generally something that, you know, I had to bring up when I would go to the doctor, but that very few clinicians that I've ever seen have asked me about this. I do think that this suggests that you're seeing, you know, doctors who are fairly progressive, but I also think that overall the numbers are still low when we think about the importance of understanding both a sexual history in terms of preventing HIV and promoting sexual health and preventing other sexually transmitted infections, and also in terms of what we can do about health disparities related to sexual orientation if we don't ask these questions. So let's move on from the polling questions, and thank you very much for sharing that information. But I wanted to speak about getting to know your patients. And to follow up from what we were just talking about, if this man came to your office, how do you decide, or how do you determine whether this is a new patient or a new gay patient or a new patient who is a man who has sex with other men? And I think one of the questions that I often ask clinicians when we talk about this is, you know, how would you feel when you learn this information? Would you feel comfortable talking to someone who's gay? Is this something that would make you feel like you needed to learn more in order to do this, or would you feel like you really just didn't want to take care of somebody? So I think as primary care clinicians working in community health and seeing people who are vulnerable populations, I dare say you are seeing people who are LGBT, and that it's important to be thinking about this as we see patients. These are 2 studies that were about HIV, but I'm actually showing them, this was a study, I'm actually showing it for a different reason, which is that in this study of proportion of physicians who discuss topics with HIV positive patients, the CDC had published this and shown that 84% of clinicians spoke to their patients about use of antiretroviral therapy, but only 14 to 16% talked about more intimate issues that are very important in terms of HIV prevention, like condom use or understanding HIV transmission and other aspects of risk reduction. This led the Institute of Medicine in a report that came out in 1997 to say that, ironically, it may require greater intimacy to discuss sex than to engage in it. And I dare say that, you know, the Institute of Medicine tends not to say things that they don't feel strongly about and that there's not a fair amount of evidence on. But I do think that there's been a lot of study and a lot of data over the years that really show the reluctance of clinicians to engage in discussions about sexuality, sexual orientation, sexual behavior with their patients. And we have to think about what we can do to help overcome that barrier. So first, I think the issue is, what do we do in clinical settings? And clearly, we need to think about how we talk with our patients. Frequently, I think what I'm doing today is called a discussion of cultural competence. I always find that term a bit uncomfortable because it makes me feel like I have to learn a lot more than I know. But I feel like in the realm that we're talking about things that we already know, but we're sometimes a little bit afraid to actually discuss it with people who we don't know very well. But I think experience has shown that if we approach people with questions that are respectful, empathic, and just demonstrate genuine curiosity and concern of a clinician, that people generally feel fine about it and are willing to talk to their clinician about these issues once they've understood that it's part of a routine question that you'd ask all patients, and that it's important for overall health care for all the reasons that we've been discussing. So in terms of taking a history from an LGBT patient, I'd say the core of the history is the same as it would be for any other patients, keeping in mind the unique health risks and issues that we've discussed above. First of all, one of the things that I think is important is just really having some time to get to know your patient as a person, understand their life situation, who they live with, etc. And information about their sexual orientation may come out simply by just saying something like, "Tell me about yourself," and giving them time to talk about their life and what they do. That may not always be the case, and obviously if someone comes in with something like chest pain, you don't have the luxury of having this kind of unstructured time to talk to somebody about something like this. But nevertheless, I think it is available in a lot of primary care visits. It's important that until you know somebody, you use gender-neutral terms and pronouns when referring to partners. So, for example, do you have a partner or spouse? Are you in a relationship? And what do you call your partner? Rather than assuming if you're seeing a man or a woman that you should refer to their partner as somebody of the opposite sex. Obviously, we have to avoid judgment or bias in all of our conversations and be open to evolving terminology, such as queer, which we've mentioned, and same-gender loving, which is an increasingly mentioned term among African American men who have sex with other men. And again, this may vary from one part of the country to another, but it's a new terminology that I've begun to hear a lot. And again, there may be many others, but I think we have to be open to listening to our patients and understanding what it is they're telling us. As I've said before, I think when we get to the sexual history, it's important to contextualize it and make sure that patients understand that it's routine and confidential, and say something like, I'm going to ask some questions about your sexual health that I ask all of my patients. The answers to the questions are important for me to know to keep you healthy. We want to talk about sexual health as well as behavior, so that we want to talk about satisfaction with sexual function, and also just assess someone's comfort with their sexuality with a question like, do you have concerns or questions about your sexuality, sexual identity, or sexual desires? If you really don't learn a lot about people, we do have to get more direct. And then in terms of assessing sexual behavior, we might resort to questions which are fairly straightforward but also non-judgmental, and say, have you been sexually active with anyone during the past year, including oral, vaginal, anal sex, or other kinds of sexual practices? And that if someone says yes, ask if they're sexually active with women, men, or both. It's also relevant to ask how many sexual partners people have had in terms of assessing risk of HIV and sexually transmitted infections, and would have an impact on what recommendations you might make about recurrent HIV testing. Again, not just talking about sexual behavior, but we also would want to assess risk for HIV and sexually transmitted infections, and ask somebody what they do to protect themselves from HIV and sexually transmitted infections, what they do to protect themselves from having a pregnancy. If someone uses condoms or latex dams, talk to them about how they use them and how often they use them. If barrier use is not consistent, try and understand when they do use it and how they make decisions, and help them develop a plan to stay safe. And finally, talk to them about whether or not people use alcohol or drugs when they have sex, and whether their partners do, because again, that's a correlate of unsafe sexual practices that I think it's important for clinicians to learn about. None of these things are particularly complex issues, but it's worth kind of practicing or doing role plays in your office or with your staff or with, others to try and sort of begin to feel comfortable asking these questions. But no one's going to say anything that is not going to be relatively easy for you to kind of process and talk to them about, I think, if we follow some of the issues that we've been discussing. It's also important to discuss gender identity with patients. It can be complex due to the fluidity of expression for some, and as I mentioned before, the rapidly changing terminology. A lot of people think that information on gender identity can best be obtained using sort of structured data that's obtained in advance of the visit, either input into a web-based patient information system from self-report at home or at the time of registration. In clinical settings, providers can again feel comfortable asking people if they have questions about their gender identity. I recently talked with a group of very mixed group, and people said that when they were asked these kinds of questions, they felt perfectly comfortable with it. Again, if they understood that it was something that was important for people's health and that it was done routinely. And that depending on the answers to these questions, you would want to follow up as appropriate. And finally, we didn't talk about desire, but it's important to ask people whether they have any desire about people of the same sex or issues related to gender identity. And there are many people who come out at young ages, but there's also a lot of people who come out at older ages and may be thinking about things like same-sex attraction for a good part of their lives. So as clinicians, we're the ones who can really help people kind of express these things and get the support they need to live the life that's going to make them happy. And I think that this is an important consideration for us in community settings. At the Fenway Institute, we've just published 2 policy briefs about gathering information on sexual orientation and gender identity in clinical settings, both why and how to. These are available on the Fenway Institute's website, and we'll have the address at the end. But it really begins to go from the clinical setting to the electronic health record and what we need to do to gather information more routinely as part of the electronic health record. So that at Fenway, we've recently added to our demographic field the field that has the red circle around it, number 7, regarding sexual orientation. Do you think of yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, or don't know? This kind of structured data was developed based on focus groups with patients, both straight and gay, and is a way of having structured data that we can use to look at both the care of individuals, but also to look at population-based care across those we take care of here at the health center to ensure that there are no health disparities. We're currently doing similar study of questions to be asked of transgender individuals, and this is a more complex issue, but our goal is to come up with a similar set of questions which can be routinely reported by individuals voluntarily, again, either at home, if there is a web-based interface so that people can report their demographic information from home, or at the time of registration. I wanted to end by talking a bit about broader issues, creating change in terms of the environment for caring and working. And here are a scattering of pictures from different institutions around the country that are looking at different ways to create welcoming environments which are prepared to care for LGBT people. I know that a number of hospitals around the Boston area have recently talked with us about how we can help work with their office staff or how to create policies which are non-discriminatory and indicate that to patients so that they're seen in a positive light. We've actually had questions about this from around the country. And again, I think it's an important area for consideration. So that we want to know, do people feel welcome and safe to disclose their sexual behavior and identity? Do you know if people who work at your health center, clinicians, whether they're clinicians or staff or students, feel safe and accepted? Do people feel comfortable being themselves at work? Can people talk freely with colleagues? Is there an organizational structure to adjudicate any concerns that might come up? Do you have educational programs to teach about LGBT health issues? And, you know, what does your board of directors feel? How can you, as an executive director, how could you get your board on board with really taking care of some of the healthcare disparities that we've been discussing today? The Joint Commission has advanced a number of issues related to this and has published them in a field guide on LGBT health. And I recommend that all of you look at this because while their focus is hospitals, it will apply to health centers. And it will take us into the patient environment, which would mean creating forms, as we've talked about, that include the full range of sexual and gender identity and expression, looking at staff training, having a non-discrimination policy and posting it, displaying images that reflect LGBT life, posters with same-sex couples, rainbow flags, trans symbols, having educational brochures on topics regarding the health of LGBT people, and unisex bathrooms so that transgender individuals feel comfortable going to a bathroom where no one's going to question whether they have reason to be there. I also think that when we think about issues we're facing in terms of, let's say, the growing incidence of HIV among Black and bisexual men who have sex with men and gay men, that there are opportunities for health centers to have support groups for people to really think about whether they live in two separate worlds or whether or not they can create a community where all of their identities are accepted. This is just one example of a program that we're running here at Fenway, and I think it's something that many of you might be interested in. Finally, we need to involve the broader community, and this is a slide from the It Gets Better project to help people hear from others about what it's like to be different when you're younger, but what happens when you get older, and is a national program focused at LGBT youth. But this is only one example, and this was a video done by the president, but I've been at health centers where they've done It Gets Better films and videos that get posted on this website. I've been at hospitals, medical schools. There's opportunities for you to demonstrate to your patients that you do care about these issues in a very positive way, and it can make a big difference. I think that a big part of our mission in the community health movement is enhancing human rights and enhancing health. And clearly, LGBT people are a big part of the population you care for, so that creating information for patients, having educational programs, and creating change in your health center, and this is a photograph of the Fenway, are things that you can be doing. We do work at Fenway Health, which is in Boston. It's a federally qualified health center founded in 1971. We do care for the LGBT community, but also for anyone in the neighborhood who wants to come here to access health care. We have an integrated primary care model that includes HIV services. That's a model that was developed as early as the mid-1980s. And we also have the Fenway Institute that does research, education, and policy work, which is the home for our Education Center. The Education Center has been in existence for a while, but we just got a HRSA National Cooperative Agreement this year to provide training and technical assistance for health centers, and that's that grant which funded this webinar. We also provide grand rounds for faculty, staff, and trainees at academic medical centers in a program sponsored by the American Medical Association. We do consultations for health organizations on creating strategic change, and we have a variety of resources. This last slide has information about our needs assessment so that we can learn more about what your needs are, and feel free to contact any of us here at the National Center to get more information about our programs as you see fit, and you'll be able to download this information. And now we have about 10 minutes left for questions, so I'll turn this back to Jared, who can moderate us through whatever questions people have.
Great. Thank you very much, Dr. McAdon, for that great presentation. And now, as you mentioned, we'll have a short question and answer period. To ask a question, please click on the chat button and type your question into the chat box. Once you do so, I'll read it aloud for the group to hear. And please take this opportunity to share with us your questions or any comments you might have about the presentation. All right, and we are getting some comments and questions in. Corey writes, thank you very much. Do you know of initiatives to improve training for medical and other health profession students and postgraduate trainees to increase competency in LGBTQ health?
I guess I'd ask where you are. I mean, we certainly do programs all across the country and have been doing that for a number of years. I guess I would say I'd be interested in, having a conversation with you and talking about how we could be helpful, and also point you to other resources that might be closer to where you are.
Great, thank you, Corey. And you can always reach us here at the AETC NCHCMC, and we can take your questions and forward them to Dr. McAdon for his answers. And another question we are getting in from Roseanne is, do you have some suggestions on outreach to the LGBT community for cancer screening?
I think the answer is that we, cancer screening for the LGBT community, with a couple of exceptions. So, for example, men who have sex with men who have HPV may be at higher risk for anal cancer. But in general, cancer screening for LGBT people is not really different from cancer screening for others. I think the issue is that we have to be clear about that, and that would be an ideal topic for a patient handout so that people understand that the screening guidelines at this point would be exactly the same for a lesbian, gay man, or bisexual person or transgender person as they would be for other people. I think one thing that we have to consider is that in transgender individuals who have had surgery, we have to think about, what anatomy has to be looked at. So a trans woman would still have a prostate gland, and so you have to think about doing routine prostate testing. And, this could be complicated by hormonal therapy. But those are the kinds of medical things that we would think about with other patients. It's just that we have to sort of just get in the custom of realizing that LGBT people are people who need pretty much the same health screening as anyone else.
Great. Thank you very much for that question. And Nadine asks, do you have any programs for children of these patients?
I don't. When you say children of these patients, I guess I'm not exactly sure what you mean. There have been a number of studies of children of same-sex couples demonstrating that their development is completely normal and fine. There are organizations that have, support groups for kids of same-sex couples. I think that, it would depend on the issues that are coming up in a specific community and whether there's interest or need in doing that. This is obviously a topic of great importance, and there's a significant amount of research being done now on children growing up in same-sex families, but there's no indication that there's anything different for them than there would be for anyone for growing up in a traditional heterosexual family.
Great, thank you. And we are getting a question from Susan. Susan asks, the demographic data collection tool for our EMR does not address the T in LGBT, but does use the term homosexual. Does homosexual include transgender?
I'm glad you brought that point up. Homosexuals or issues related to sexual orientation have really no relation to gender identity issues or transgender issues. And so it's important that we ask questions related to sexual orientation and also ask questions related to gender identity. A transgender person could consider him or herself straight, bisexual, homosexual, and there's really no correlation between sexual orientation and gender identity. So it's really best to think about asking questions related to both sexual orientation and gender identity separately. Now, having said that, what questions to ask is a little bit more complex. And as I mentioned in the talk, some people feel that while it may be comfortable to have a conversation about sexual orientation, it may make sense to have a screening form that includes information for options around gender identity so that people can fill out in advance of seeing their clinician.
Great, thanks. And Susan had a follow-up question. She says she was referring to the intake tool presented earlier.
Yeah, the intake tool, I think I'm sorry if I wasn't clear. The intake tool which I presented in the talk today is the one we're actually using here at Fenway. And the sexual orientation question is the one that we've done research on already. We're still in the process of doing focus groups and finalizing the questions that we would ask with respect to transgender patients or issues related to gender identity. There are some sample questions which we could make available, which I have, but were not presented in this talk, that are recommended by a transgender group in California, and that, Susan, if you wanted to email us, we could send that to you.
Great, thank you, Dr. McAdon. And this concludes the webinar for today. For those questions we didn't get to, we will post them and the answers on NCHCMC.org along with the presentation and a link to the recording. So in conclusion, I would like to thank you, Dr. McAdon, again, and thank you, Mr. Salazar, and thanks to all of you for joining today's web conference. You can visit.
Thank you very much, everyone.
Oh, thank you. And you can visit www.nchcmc.org often to learn about additional webinars concerning HIV in primary care. Once I've ended the presentation, an evaluation will replace your WebEx screen. Please take a few minutes to complete the evaluation and give us your feedback. If you have any questions about today's webinar, the Fenway Institute, or the AIDS Education and Training Center's National Center for HIV Care in Minority Communities, please email the AETC NCHCMC clinical team at clinical@nchcmc.org. Thanks again, and I hope you enjoy the rest of your day.
Hello, guys.